we can share it with folks who are not able to make the call today but would really like to learn some of this information at a later date. So thank you all for taking time out of your busy days to learn a little bit more with us about LGBT care in Oregon and around the nation. This webinar is one in a series from OPCA on special and vulnerable populations. To let you know, the last webinar we had, we discussed HIV/AIDS care in Oregon. And then the next upcoming webinar that we have scheduled for August is going to be focused on food insecurity. If you want any more information on resources and info from the last webinars we had or future webinars, please feel free to go to our website or to connect with Stephanie Castano, who is the person who probably sent you the invitation for this webinar. So you should have her email. So today we're going to be learning from two great folks, great resources that we asked to join us to share their knowledge. First, we have Dr. Kevin Ard with us, who is speaking on behalf of the Fenway Institute, which is a national cooperative. What that means is they are a resource for all of the FQHCs around the nation, and so they can provide technical assistance to you directly, and they also provide it to the PCAs like us, and their focus is on LGBT health specifically. And I'm sure Kevin may even have some more information to share on that with you. So Kevin is currently a faculty member in the Division of Infectious Diseases at Massachusetts General Hospital and an instructor in medicine at Harvard Medical School. He has written and lectured widely on LGBT health disparities, on intimate partner violence and LGBT relationships, and on HIV prevention. And he has current interests that include LGBT health education, the intersection of clinical medicine and public health, and the care of patients with HIV and hepatitis C. So he is definitely an expert in this area, and we are very excited to have him join us today to share some information with all of us. After Kevin, we have Jazz from Outside In, and Outside In is a homeless youth FQHC located in downtown Portland, and I would venture to say they probably see a higher percentage of LGBT patients than pretty much any of our other FQHCs. And so they actually have Jazz, who is the trans coordinator, as well as lab. Yeah. And so Jazz is going to be sharing with us some of the information about the care that they provide, and specifically the kinds of benefits that can be received around trans care. And I'll let Jazz fill you in further on the details of that, because I am no expert. And I also just wanted to mention that Jazz, along with, I believe, two of your colleagues, is going to be doing a training for medical assistants very soon on Saturday, June 13th, here in Portland, Oregon, on transgendered healthcare. It's a basic training for frontline healthcare personnel. So if anyone is interested in having their MAs attend this training, let us know, and we'll make sure to get you the information on that training Saturday, June 13th, from about 8 to 10:30 a.m. at the Portland Providence Medical Center. So these are the two presenters we have with us today, and that's pretty much all I have to share with you intro-wise. We're very excited to learn ourselves here at OPCA about care for LGBT individuals. And so with that, I am going to go ahead and bring Kevin on. So give us 1 second to switch over our PowerPoint presentation. All right.
Okay,
Kevin.
Well, thank you very much. It's great to be here. Thanks for the invitation. And I'm looking forward to talking to you today about caring for LGBT patients. I'll mention several things that apply to the national context, and then Jazz will also help bring it home to Oregon later in the webinar. So the objectives for this part are first to talk about LGBT concepts, demographics, and terminology, so that we're all on the same page when we're discussing these issues. We're then going to spend some time talking about health disparities that affect LGBT populations and the role that stigma plays in promoting those disparities. And then finally, we'll talk about ways to make clinical settings more inviting for LGBT individuals. So first, concepts, demographics, and terminology. I want to spend a bit of time talking about this term LGBT because it's used very frequently. And of course, this means lesbian, gay, bisexual, and transgender. Whoops, the presentation just went away. But I think it's helpful to think about what shortcomings are of this term. One shortcoming, I think, is that people talk about the LGBT community or the LGBT population, but there really is no such thing. There's no single community and no single population, but many different populations that are often referred to when we use the term LGBT. I think another issue is that this term only refers to people who identify as lesbian, gay, bisexual, or transgender. Technically, it doesn't include men who have sex with men or women who have sex with women who don't identify as lesbian, gay, or bisexual, for instance. And we'll talk a bit about that also. And then finally, this term combines sexual orientation, which is identified by the LGB, and also gender identity, which is referred to by the T. But these are really separate things. They're not the same concept, and I think sometimes it can obscure that difference to combine them in this way. That being said, I don't have a better term, and so I'll also use the term LGBT throughout the presentation, but it's helpful to keep those shortcomings in mind. So first, a few words on sexual orientation. Everybody has one, not just people who are lesbian, gay, or bisexual. It may change over time. We see that especially with adolescents, but it certainly can change in others also. It's not the same thing as gender identity, and we'll talk about that more in a bit. And then I think that sexual orientation has three different dimensions. They're identity, behavior, and attraction. And as shown by this Venn diagram, they don't always overlap in a given individual. If we're just talking about behavior alone, we might use the terms MSM or WSW. Those stand for men who have sex with men and women who have sex with women. But using those terms doesn't imply anything about whether someone identifies as lesbian, gay, or bisexual or not. So to help further underscore this issue of how behavior is not the same thing as identity, I want to show you some data from NHANES, which, as you probably know, is a large national survey. And in that survey, less than half of people who have sex with people of the same sex identify as lesbian, gay, or bisexual. There was also a survey done in New York City in which about 3/4 of the men who reported having sex with other men actually identified as straight, not as gay or bisexual. And compared to men who identified as gay, these men were more likely to be foreign-born or to be of lower socioeconomic status or married. Now, I think it might be tempting to say that perhaps these men just haven't come out yet as gay, but I think that that's an oversimplification. I think that many of them do not identify with the gay label and would never adopt that publicly. The bottom line is that you don't know someone's sexual identity until they tell you, and it is whatever they say it is, because they're the ones who define it. Now a few words on gender identity. Again, everybody has one. It's not the same thing as sexual orientation. And it refers to one's internal sense of maleness and or femaleness. This brings us to the T in LGBT, which stands for transgender, and that means that one's gender identity is not congruent with one's assigned sex at birth. Some other terms that you may have seen are transgender woman, trans woman, male to female transgender person. That's someone born male who identifies as female. The converse is a transgender man or a trans man or a female to male transgender person. You may have seen the terms gender fluid and gender queer, and that can mean different things, but people often use it to mean that they reject a binary gender classification and identify as some of both or neither gender. The term cisgender is, I think, becoming increasingly used, and that simply refers to someone who is not transgender. And if any of you took organic chemistry in school, the cis and the trans come from chemistry terms for the orientation of different molecules. In any case, that's someone who is not transgender. And then I also want you to know about this term gender dysphoria, which is a diagnosis in the DSM. That's the manual that psychiatrists use in the United States. And this refers to distress that people may feel if their gender identity is not congruent with their birth sex. This replaces an older term called gender identity disorder, which referred in many ways to the state of being transgender. And that diagnosis was thought to be stigmatizing, and so it was replaced with gender dysphoria, which does not try to make being transgender a disorder, but refers to the distress that some people may feel if their gender identity is not congruent with their birth sex. And I mention this because many healthcare professionals require a diagnosis of gender dysphoria before prescribing hormones or undertaking sex reassignment surgery for transgender individuals. Now, I've been mentioning several times that sexual orientation and gender identity are distinct concepts, and this is some data that supports that. It comes from a survey of more than 6,000 transgender people across the U.S., and you can see that essentially every sexual orientation is represented in this sample. So being transgender does not necessarily mean that one is gay, lesbian, bisexual, straight, or whatever the orientation is. People who are transgender often speak of a process of gender affirmation. Some may also call this the transition. And it often entails moving from living publicly with one gender expression to living publicly with another gender expression. And it has several components. One is the social component. Transitioning often involves being honest about one's gender identity with family, friends, coworkers, colleagues, and so forth. It's a legal process, and I think that Jazz will say a few more words about this later. But people often want to change their gender identity on official forms of ID, like driver's licenses. And one reason for that is that if people present an ID that indicates a gender which is not the way that they are themselves expressing themselves, people say that they're open to more harassment and discrimination. And then also it's a medical process for many people. It may involve hormonal therapy or sex reassignment surgery. Although in some cases, sex reassignment surgery is prohibitively expensive and hard to obtain. I think that Jazz will also say a few more words about that. So let's move on now to demographics. And I want you to think about the answer to this question. The number of Americans who identify as LGB is closest to the population of which state? And the answer here is actually Ohio, which has 11 million people, or about 3.5% of the US population. Now, some say that this is an underestimate because it comes from a national phone survey, and people may not be willing to identify as LGB on the phone to a stranger. But it's the best data that we have on this topic. And this is how that number breaks down across the country. The state with the lowest proportion is North Dakota at 1.7%. The state with the highest proportion is Hawaii at 5.1%. And then Oregon is here at 4.9%, which is relatively high in relationship to the rest of the United States. What that underscores to me is that many of the patients that you may be encountering in your clinical settings may be lesbian, gay, or bisexual. You simply may not know it in many cases because it hasn't been asked or the patient hasn't disclosed that information. You may notice that Washington, D.C. has a relatively high proportion at 10%. And that reminds me to tell you that many metropolitan areas have much higher proportions of people who identify as LGB. The metropolitan area with the highest proportion is San Francisco, although many other metropolitan areas have also relatively high proportions of people who identify as lesbian, gay, or bisexual. What about transgender people? The number of transgender adults in the U.S. is closest to the population of which state? And think about what you would answer to yourself. The answer here is actually Alaska, which has about 700,000 people, and that's 0.3% of the U.S. population. We know this number with much less certainty because it's really compiled from a few state surveys, one in California, one in Massachusetts. Unfortunately, there is no national survey that asks about gender identity as part of the survey. I want to move now to talk about some health disparities and discrimination and how discrimination can give rise to some of these health disparities. So, unfortunately, discrimination is an ever-present reality for many members of LGBT populations, and it can take many forms. It often starts at a young age with bullying and violence in school. Sexual minority youth report much higher rates of bullying and violence and being threatened at school than other youth. In addition, there's a history of discrimination in healthcare settings. As you may know, homosexuality was considered a mental disorder up until the 1970s. And it took much longer to remove gender identity disorder from medical textbooks. Many LGBT patients report discrimination in healthcare settings. They say that providers may use excessive precautions to see them, such as gowning and gloving when that wouldn't be necessary, or that they may be refused medical care. And fortunately, the number of people who report that currently is relatively low. But that doesn't mean that many people might not still expect it when they come to see a physician, or they might have prior negative experiences that color their willingness to seek care or to identify as LGBT when they do. As you're probably also aware, there is a lot of structural discrimination against LGBT persons, and although it's improving, there is still a patchwork of laws that apply to things like marriage and adoption across the United States. And this certainly impacts the lives of many LGBT persons and also their perception of discrimination. The current model of how this affects health is through what's called minority stress. And the idea is that multiple repeated experiences of discrimination or the expectation of those experiences can lead to internalized homophobia or transphobia, can lead to anxiety and depression, which in turn can contribute to substance abuse, risky sexual behavior, and so forth. I want to say a few more detailed words about the discrimination that transgender individuals experience. I think it's always difficult to say who experiences more discrimination in terms of different groups, but I think that transgender people probably experience more discrimination in the US than other LGBT persons. And what sort of forms does this take? Well, one is that about 1/5 of people who are transgender say that they've been refused housing simply because of their gender identity. About 1/4 have been fired for being transgender. And I would note that most states in the US do not have any sort of employment non-discrimination laws for transgender status. And so there is no legal recourse for many people if they're fired for being transgender. 3/4 have been harassed at school, including by their teachers. More than half say that they've been harassed in public, such as in restaurants or hotels. Unfortunately, 25% have been harassed in a doctor's office. That may not be by the doctors necessarily, it could be by other patients or other staff, but still, I'm sure you could see how that might make people unwilling to come receive clinical care or to identify as transgender if they do. And then 1/5 have been refused medical care for being transgender. So now I want to talk about the different health disparities that affect different populations, different LGBT populations. And we'll start with MSM because that is the population for which we have the most data. So which conditions are more prevalent among MSM than other men? Well, one is certainly smoking. And in fact, LGBT populations have the highest rates of smoking of any subpopulation in the US. It's not clear why that is, although some people theorize that in the past, some of the only places that LGBT persons felt that they could safely gather were bars and clubs, and smoking norms were established in those places. Some forms of illicit drug use are more common among MSM as a whole. Crystal methamphetamine use is an example. Depression is more common, and this probably stems directly from minority stress. Sexual assault is more common among MSM than other men. Limited healthcare access is more common. We've talked about some reasons why that might be the case, a history of discrimination in healthcare. But another reason is that, at least in the past, uninsurance has been more common among MSM. One reason for that is that many companies did not extend health benefits to same-sex partners, and so people could not access health insurance in the same way as heterosexual couples. Syphilis is more common. About 75% of new syphilis infections in the US are among MSM. And then HIV is more common, and I'll say a few more words about that now. MSM account for only about 2% of the US population, but they account for almost 2/3 of all new HIV infections in the US. This data here that I'm showing you is from 2010, which is the most recent year for which we have this data. In addition, there is one demographic group in which the incidence of HIV is going up. In every other group, it's staying the same or going down. And that group is actually young Black MSM, in which the number of new infections went up by 48% between 2006 and 2009. So this is certainly a group of people who I think would benefit from more HIV prevention. People ask, why are Black MSM disproportionately burdened by HIV? And unfortunately, I don't think that we know for sure, but I would say that it is not due to differences in sexual behavior or differences in substance abuse. There are probably several other factors that contribute, the main one of which is limited healthcare access, and that has several downstream consequences. One consequence is that there is less frequent HIV testing in these populations. That means that people may not know their status, and if they don't know their status, they can't either be put on treatment if they have HIV or avail themselves of other modalities like pre-exposure prophylaxis or PrEP if they don't have HIV. There is delayed treatment of sexually transmitted infections, and we know that many of these infections actually facilitate HIV transmission. And then finally, this high prevalence of HIV in Black MSM sexual networks creates a vicious cycle, because in any given sexual encounter, someone in one of these networks is more likely to have contact with someone who has HIV than in another sexual network. What the high incidence of HIV leads to is a very high prevalence of HIV among MSM. And I've shown the prevalence of HIV in urban areas broken down by age group among MSM. You can see that at ages 18 to 24, it's already fairly high at 12%. So prevention definitely has to start early. But by age 40, it's 26%, which I would point out is the same as the adult HIV prevalence in Swaziland, which is the country in the world that has the highest burden of HIV. In Swaziland, HIV is considered a public health emergency, and I would argue that for these MSM, it's also a public health emergency. Now, there are many things that can be done to help prevent HIV infections among MSM, and I'm sure that you're very familiar with many of those: behavioral risk reduction, substance abuse treatment, condoms. But the relatively new intervention is PrEP, or pre-exposure prophylaxis. And I want to say a few words about that because it's really the newest kid on the block. It's indicated for people at high risk of HIV infection. Young sexually active MSM with multiple partners would be one of those groups. And it consists of a pill that has 2 antivirals in it, tenofovir and emtricitabine, that's taken once daily. People generally tolerate it very well. Some people have a bit of nausea that goes away with time. Serious side effects are quite rare. And the efficacy is highly dependent on adherence. In people who take the medication daily as prescribed, it's reduced the risk of HIV by above 90%. And given that we have this burgeoning epidemic among young MSM, especially young Black MSM, I think it's important that clinical settings that see these patients be prepared and able to prescribe PrEP as much as possible. Let's move on now to talk about women who have sex with women, or WSW, which conditions are more prevalent among them than others. The top of this list is the same as for MSM. Smoking, drug use, depression, sexual assault, and limited healthcare access are all more common. And then overweight and obesity is also more common for reasons that I think are not entirely known. We also know that WSW are less likely to be screened for cervical cancer than other women. Common reasons for this are that they may not have insurance, and we talked about why that might be the case. They may have had prior negative experiences with screening, and so don't pursue it again. Or there may be a belief on the part of the patients or the providers that screening is unnecessary for WSW. And this belief stems from the idea that women who have sex with women have lower rates of human papillomavirus infection. HPV is the virus that leads to cervical cancer. But we know that that's not necessarily the case, and that HPV and high-grade cervical lesions can be found in some women who have only had sex with women. It's thought then that HPV could be passed between women. And also, most self-identified lesbian women have had prior sexual experiences with men, and so may have been exposed to HPV in those relationships. And what this underscores is that it's important for these women to also get cervical cancer screening, and special outreach efforts or programs may be necessary to help ensure that these women are screened. I want to talk now about health disparities that affect transgender persons. And in some ways, these comparisons are not fair because transgender persons are not one population. There are transgender women, transgender men, there are people on hormones, people not on hormones, there are people who have had surgery, people who have not had surgery. And so this is a very heterogeneous group. But unfortunately, the data we have about transgender health is in general so poor and usually lumps people together as simply transgender that that's how I'm going to present it here today. So these are similar to MSM and WSW. Smoking, illicit drug use, depression, and limited healthcare access are all more common. One comment I would make about depression. 41% of transgender people say that they've attempted suicide, compared to just 1.6% of the general population. And many feel that that stems from minority stress and or gender dysphoria. Alcohol abuse is also more common. Partner violence is more common, and violence of almost any sort appears to be more common. We also think that HIV is more common. There are few data on the incidence of HIV among transgender women, but the prevalence appears to be 28%, which is staggeringly high. And among Black transgender women, it's even higher, probably around 56%. LGBT youth also face some unique challenges, and I think that these are important to mention for anyone who's caring for adolescents or other youth. Adolescence is difficult for many people, and LGBT youth have to deal with the routine struggles of adolescence, but they also have to establish a sense of their own sexual and gender identity, and often that involves negotiating it with some cultural or ethnic identity. They have to deal with social isolation and bullying. And they often face a lack of support. They may lack role models. In addition, being LGBT has been called one of the only minority statuses that people may not share with their family. And so the people that LGBT youth might normally turn to for help might not understand their plight or even be supportive. And unfortunately, many families actually reject LGBT youth. And we know that this is associated with many adverse health outcomes, including substance abuse, anxiety, depression, suicidality, and also risky sexual behavior. It also, in many cases, probably promotes homelessness. Up to 40% of all homeless youth are actually LGBT, in many cases because they've been kicked out of their families of origin. In the last part now, I want to say a few words about creating a welcoming environment for LGBT persons. I think the first step for any person or any clinical setting in terms of making their environment more welcoming is first some self-reflection. Do people harbor biases or stereotypes about LGBT people, and where do those come from, and how might they impact their ability to care for LGBT patients? I think that people who are providers have to ask themselves, are they comfortable discussing same-sex sexual activity with patients as part of a sexual history, for instance? And then, do LGBT staff in the workplace feel comfortable living openly? If the answer is no, then I think it underscores that it may not be a welcoming place for patients either. So what does LGBT-friendly care look like? I would point out here this reference from the Joint Commission. The Joint Commission made a field guide with several different recommendations for making care more LGBT-friendly. Some things that we know are that LGBT persons tend to scan the environment for clues to acceptance. So posters in the waiting room or in the exam rooms, the imagery on brochures and pamphlets, all those things matter greatly. And I put an example of a sticker up here that indicates an LGBT-friendly atmosphere. Language matters greatly. It's important to strive for neutral terms on forms and during the clinical encounter. For transgender patients, it's very important to use preferred names and pronouns and to document those so everyone involved in someone's care can use those preferred names and pronouns. A very common scenario is that a patient will have a legal name and a legal gender that's used for insurance purposes that does not match their gender identity or their preferred name. And if, for instance, a medical assistant goes into the clinic waiting room and calls a patient by their legal name or says Mr. Smith, when Mr. Smith actually identifies as a woman and may use a different name, the patient may feel very unwelcome and may not even respond, for instance. It's important to reflect patients' descriptions of their relationships. If a man tells you that the man accompanying him is his husband, I think it's important not to call him his friend or his partner. And what this often boils down to is avoiding assumptions of heterosexuality or gender conformity. I think that LGBT-friendly care also involves developing a policy of non-discrimination on the basis of sexual orientation, gender identity, and gender expression, and displaying it prominently so staff and patients can see it. And then all staff members, and especially frontline desk staff, should be trained about LGBT-friendly care. We also think it's important to start systematically collecting information on sexual orientation and gender identity of all patients who come to the clinic. And there are several reasons for this. One is that it does indicate a welcoming atmosphere, that the clinic is interested in this topic and wants to know this information. It can help providers provide appropriate care. For instance, there are specific health recommendations that apply to MSM that are put out by the CDC. And I think it also allows clinical settings to better understand the populations that they care for as a whole. There actually have been some demonstration projects of this done in both settings that have a high number of LGBT patients and settings with a low number of LGBT patients. And in general, these projects have shown that people are willing to answer these questions, they understand them, and that they feel that they're important. So what can the questions look like? Well, you could consider adding a question like this to the registration form in the clinic. Do you think of yourself as lesbian, gay, homosexual, straight or heterosexual, bisexual, something else, or don't know? And then for gender identity, a 2- or 3-part question is recommended. Ask people about their current gender identity and leave a space where people can write in something else if their gender identity does not match one of the options. It's important to find out what sex they were assigned at birth. That's crucial for people's medical care. And then also, what is the preferred name and the pronoun that can help with some of those issues that I mentioned before. As was mentioned in the introduction, the National LGBT Health Education Center at the Fenway Institute in Boston has developed many resources for primary care associations and for community health centers. And those can be found on our website, which I've put here. We have webinars that you can watch on demand. There are many publications that focus on different topics. And there are also several learning modules that you can work through. It would be too difficult to summarize all the topics that we touch on there, but some things include affirmative care for transgender people, promoting cervical cancer screening for WSW, tobacco cessation, more on how to collect sexual orientation and gender identity information routinely of all patients, and then many more topics. So please check that out if you're interested. I hope that you take home from this that LGBT encompasses diverse populations that share experiences of discrimination based on sexual identity or gender identity and expression, but otherwise may be quite different. These populations face health disparities that often stem from this discrimination. And I think what LGBT-friendly care boils down to is being open-minded and avoiding assumptions. So with that, I want to thank you very much, and I'll now pass the baton over to Jazz to continue the discussion about some more Oregon-specific information, and I think that there'll be time at the end for questions.
Great, thank you so much, Kevin. This is Claire, and we're just going to take a moment here to switch out our presentations so that Jazz is all set. That was a lot of really great information, and I appreciate hearing about the specific disparities that exist and some of the things we can do to address them. So we will be sending out information after this webinar, the slides that you've seen in front of you, as well as links to the Fenway Institute so that you can access all of those additional resources that Kevin mentioned. And as Kevin said, we will save a little bit of time at the end for questions, but please do feel free to type any questions into the chat box as we go, and we will review those at the end and make sure that we get them answered to the best of our ability. So, Jazz, you are on.
Great, thank you. My name is Jazz McGinnis. I am the Lab and Transgender Services Coordinator at Outside In, which is a FQHC that serves primarily homeless or unstably housed folks, but a lot of our programming has to do around youth and LGBTQ youth. I have been in this position for about 2.5 years, and I do a combination of activism, coordination of our transgender-specific health programs, and I'm also working on a task force with several other community organizations to impact the policy around the Oregon Health Plan and transgender care. I also identify as a transgender man, and I use the pronouns he and him. And in this presentation, I'll be focusing more on insurance and healthcare systems, where Kevin gave a lot of information, a lot of great information about identities. there we go, slides. So kind of leading back into what Kevin was saying about what transgender folks experience in daily lives. So 41% of folks can't change their IDs, 50%, 57% rejected by families, a large percent experiencing homelessness, being refused medical care, and like Kevin said, almost 50% of trans folks have either attempted suicide or there's also a high amount of folks who have committed suicide. And then down below, I just wanted to put in that infographic about trans folks who lack health insurance or are not able to get health insurance because they're denied care. And then going back to Kevin's fear of interacting with providers who have no experience working with trans folks or who are going to ask their own patients to educate them, or they just can't afford the services necessary for their transition. So one thing that happened really exciting here in Oregon is beginning January 1 of this year, the Oregon State Public Health Plan, or OHP, said that they would start covering transgender health care and also refer to that as transition-related health care. That includes things like hormones, office visits, laboratories to check for hormone levels, specialty office visits, mental health care, and some surgical services as well. In the context of how this helps our clinic, our population, most of our patient population is outside in are folks that are under the federal poverty level, and so this is huge for our patient population because now they have access to Medicaid, which will cover these services for them. So the covered services that are mostly big for transgender folks in Oregon are access to hormone replacement therapy, or HRT, and then access to surgical services. So I'm focusing on kind of the medical aspect of transition. Kevin touched upon kind of the social, professional, other aspects of transition, and I'm focusing on kind of medical services here. So hormone replacement therapy is a big step that many trans folks take to change their body to match their gender identity. And this is now covered by the Oregon Health Plan. So again, prescriptions for hormones, labs, office visits, and this is also now by the Oregon Health Plan not requiring a letter from a therapist. So a traditional model for hormone replacement therapy would be a transgender person would have to go to a therapist for an undetermined amount of time in order to get a letter from a therapist saying that this person is competent in knowing who they are, they know their identity, and then they can take that letter and go to a provider and then access hormones. So that letter is no longer necessary. It's up to provider discretion whether they will ask for a letter or not, but many providers are able to go ahead and do hormone replacement therapy without that letter, which is fantastic, and that helps meet this huge demand for trans folks trying to access hormones. Surgeries are a little bit more complicated right now. With the policy that was put forward in Oregon, there's a certain number of surgeries that are covered. So some of the most common ones, or not common, but one of the ones that are accessible right now are mastectomies or chest reconstruction for trans men, orchiectomies, vaginoplasties, and hysterectomies. One of the problems that we're running into here in Oregon is there's a limited number of qualified surgeons here. We have a couple of surgeons who can perform chest reconstruction for transgender men, and we have one surgeon or two surgeons that are able to perform orchiectomies at this time, which is the removal of the testicles. But with the kind of huge demand for surgeries, there are wait lists and kind of this issue of needing to find more people that we can work with. one of the biggest things is that in order to get surgeries, people are required to get 2 letters from qualified mental health practitioners, and these folks have to be at least master's level clinicians. My patients at Outside In and many of other folks that I run into are having trouble getting these letters. A lot of transgender folks have access to a first letter because they have been in therapy for one reason or another, and it's the second letter that's having a hard time for people to access. And probably the most common reason is that is happening is that a lot of transgender folks are trying to access that second letter, so there's a backlog of therapists who can write those. From a primary care perspective, patients do not need necessarily a letter from a primary care provider to refer to someone to surgery. If you have a referral process in your office, you can go ahead and use that, and that will count as a letter from a primary care provider. But people do need those 2 letters from qualified mental health practitioners, which is kind of a big thing right now. So barriers to accessing care for transgender folks, Kevin went over a lot of them. Here in Oregon, we've had our own kind of specific issues. So one of them kind of started with enrollment with Cover Oregon, where we had folks who were applying for the Oregon Health Plan under their preferred name and preferred pronoun, and then when the application would go back and try to match against the Social Security information that has someone's legal name and legal gender, there would be a mismatch. And so that would kind of kick the application back or kick the application out, or it would get lost in the void of space. It would go somewhere, and the person's coverage would not happen. And so one of the big issues was working on finding people who were understanding of the difficulties that transgender folks had enrolling in care. So finding people that were able to navigate the process of saying, because, of this reason, because Social Security is matched with your insurance, we need to use your legal name, although I understand that this is the name that you want to use. So putting it in a context that, helps trans folks understand that this is part of a system and not necessarily like an individual discrimination that's happening. Identifying competent providers has been an issue, and it's been an issue for transgender folks for a really long time. Transgender care has mostly been underground, word of mouth. So I find a provider who will prescribe hormones to me, and my friend David is looking for a doctor to prescribe to him, and I tell David to go to my doctor because I don't know anyone else, and he doesn't know anyone else. So it's this kind of word-of-mouth referral, which doesn't help when we're trying to roll out the Oregon Health Plan and get people to providers who can provide great and quality care to transgender people. There are lists that are happening within the community, and I've linked to those at the end of this presentation. But also the coordinated care organizations and other institutions are not kind of finding ways to get these lists together, are not right there. AppleCare in Washington is starting to try to assess providers for their competency, but not sure what that kind of test or what those qualifications are going to have to look like. In terms of accessing competent providers, there's just like I said, no one really identified at this time having trouble with. For miscommunication and misunderstanding around provider or around coverage, so one is with patients and patient expectations and managing those. When this rolled out January 1st, with my clients, the impression I got is that everyone thought that they could get surgery the next day, January 2nd, and that it would be beautiful and there was an infrastructure and that it would happen. And I really wanted it to be that way, and we're still working on finding primary care providers, surgeons, kind of getting all of this kind of in control, so getting protocols, getting all of that together. patients can access services. Primary care providers are unclear of what they need from patients and from the provider side, so protocols for treatment, what sort of letters need to be written, kind of how to go about doing transgender competent care. Again, like Kevin was talking about, making sure frontline staff are trained to use preferred names and pronouns, making sure your EHR programs have ways that you can put in preferred names and pronouns. So making sure that we're able to put those things in place to make sure that people are getting quality care and are understanding their coverage. Another thing with coverage is that there are different answers for different situations, for different people, for different CCOs. So right now, there's nothing standardized right now, which is really difficult because one person's CCO may say, you can have this procedure done if you do these things, and then you even call back the same CCO and they say, I don't know what you were talking about. I don't know who you were talking with. So there's a lot of misunderstanding and miscommunication that's happening right now. With standardization, again, no model policy. There's at least 12 different CCOs around the state, maybe 12, 14. And so there's no kind of standardization across all of those CCOs, and so we're getting some CCOs which are totally cool with processing applications, with approving referrals for surgery, and then there are some CCOs who are denying things. So it's kind of a little bit like the Wild West that's going on right now with trans care. Everyone's trying to figure out what to do and trying to cobble their own stuff together, but it's everyone's working on bringing it together. And that's part of the work that I'm doing with this task force with Basic Rights Oregon, folks from the Q Center, also community partner providers to try to put together model protocols that we can give to CCOs so they can implement these changes. One of my favorite stories about kind of the misunderstanding around coverage is that there are medical billing codes and specific codes for different things, and depending on those codes, they can be interpreted differently. And so, for example, one of the codes for chest reconstruction was modeled off of the code for mastectomy. And chest reconstruction is different because it involves nipple grafts, whereas mastectomy doesn't. And so we've had trans men who have called us saying they're being denied nipples. And so it's kind of looking at that and being like, okay, this is what we have. This is not exactly what we want, but we need to figure out how to make this happen so that people can get nipples. So what does this all mean for patients? So this means that patients have access to life-saving care. So like those statistics about suicidality, these sorts of treatments like hormones and surgery really are huge to transgender folks. I've had a patient that called me a few weeks back who told me that she was going to perform her own orchiectomy if she could not get coverage. So thinking about how if trans folks don't have access to their own coverage, they are going to self-mutilate their bodies so that they can get what they need. And now having CCOs saying that they are required to provide care to their patients, to find providers, train staff, and give this treatment to folks is really huge and a huge commitment. It means, again, that patients are having to identify competent and affirming providers. And kind of the difference between those two are competent, meaning that a provider can do hormone therapy, understands protocols, and affirming, meaning I understand your identity, I understand, kind of the health disparities that have to go along with being a transgender person. I'm going to use your preferred name and pronoun. My office is set up for that. And so those things can be mutually exclusive. And so the idea is to find an office for folks where they can find both competent and affirming providers. So we definitely need an increase in competent providers for patients so that they have more people to access. And transgender people are finally starting to see an investment in their health. So for me as a transgender person, I find it incredibly just amazing that I see folks like OHP investing in care that will save my community. I see OHSU, which is doing a lot of great work with their transgender health program, trying to bring surgeons in who can provide surgeries to people. And just this message that we deserve quality health care. This is not something that we've been heard, that's something that's been messaged to transgender people before. So just knowing that people are finally saying, you know, this is something that we want to do, we believe in your population and how you're important is really cool to me. What does this mean for providers? Well, this means quite a few things for providers. So it means that providers can finally bill for services under transgender-related medical billing codes, which is huge because something, again, that Kevin talked about was we don't have data on transgender people, and we don't have data on kind of how many people or what services are being accessed and whatnot. So we can use billing codes now to bill for these services. The Oregon Health Plan does cover what they call cross-sex procedures and medications, whereas these codes, the gender identity as in an ICD-9 code or the gender dysphoria, I guess gender identity disorder under ICD-10, you can now bill for things under that and have your visit covered or be reimbursed for that, whereas if you had tacked that code onto anything before, it would have been kicked back and denied. Also thinking about using those KX modifiers in addition to making sure, adding them on if you're doing one of those quote-unquote cross-sex procedures or services. Patients are probably going to request more referrals to specialty providers and surgeons, and you'll also probably be seeing more transgender people in your practice. This is a population that has had little to no access to medical care, and now with insurance, they're going to start accessing care. So you're going to start seeing these people in your office. Which means that you need additional training to provide competent care, not only for you as a provider, but for all of your staff. One thing that happened to me recently is I had to go to urgent care and I had to go have an x-ray done. And I went into the room for the x-ray, and the x-ray technician turned to me with this little loincloth and said, "These are to protect your testicles." And I said to her, "I don't have testicles." And she looked at me like I had just blown her mind. And very quickly I said, "I'm transgender, I have ovaries." And then she was like, "Oh, okay, we need to put something special in your chart and figure out this big thing." And I was really glad that as an advocate and someone who's okay talking about that, I was cool with that interaction. But that just speaks to how many people need to be trained in your office in order to provide care that's affirming to people. So local resources in the state of Oregon, things that you can access. So you Outside In and our transgender programs are great to send people to. I'm always open as a resource. The Q Center has a lot of great supportive social services. So they have support groups. They also have social groups for folks. Basic Rights Oregon has a transgender justice health program right now that is doing a lot of great work. OHSU just implemented their transgender health program and is working to bring surgeons on board and working to create a more affirming and competent environment up there. Transactive is a great resource for any folks, transgender youth and children, people under the age of 18 and their families, where they can get support. The Cascade AIDS Project is another great resource for folks who are dealing with HIV and identify as transgender. The OregonTransHealth.com link is a link to Oregon Medicaid providers who have been identified by transgender folks in the Portland community as affirming and competent. So that's a great place to find providers if you are struggling to find someone for your patient. And then the last link is transmedicare.com. It is run by one advocate. His name is Shane Smith, and he's kind of the expert on how to help transgender people access care under Medicare. So fantastic resource. So just one short thing to talk up myself a little bit. So at Outside In, our transgender services include two things. So the first thing that I help coordinate is the ID project, which helps transgender and gender nonconforming folks change their legal identification through the courts and at the DMV, and also give information on how to change birth certificates, passport, and all that information. I do it through giving out information. I will sometimes go with people to the courthouse or to the DMV to make sure things go smoothly. And we also have financial assistance available to kind of lower the barrier around changing documentation. And then our trans clinic helps transgender and gender nonconforming people initiate hormone therapy and medically monitor hormone therapy as someone moves forward with their medical transition. Our clinic has been open for over a decade, and we have a very high demand for our services because we're the only no or low-cost clinic that offers hormone therapy in the state of Oregon. We have folks that come as far as Bend, Ashland. We also have folks from Walla Walla and Longview and Coast accessing care at our clinic. So that's something that is just not anywhere else. And right now we're doing a really exciting thing where we're changing our service and working on integrating our transition-related care into our primary care clinic. So the idea would be starting in January 2016 that someone could walk into our primary care clinic and begin the process to start hormones instead of having to stay on a wait list for a while and get into our clinic. So we're really excited about moving into primary care and working on that program. So yeah, thank you for listening. This is my lovely picture about cats. I include cats on everything I do. The last thing I wanted to mention is that there is an LGBT health conference that's happening at the National College of Naturopathic Medicine in July, and I'll be presenting there about some of the same topics.
Great. Well, thank you so much, Jazz. We just learned a whole lot from you, as well as Dr. Kevin Ard. I believe this is going to end the official part of our presentation, but we did want to allow some time for questions. So those of you who would like can stay on the line, and I think Jazz and Kevin are willing to take a few questions, because this, I think, is a question-inducing kind of presentation. So let's see. I'm going to take a quick peek and see who's got some questions typed in. And we'll start there. So one moment. All right, great. We have an offer, one for Jazz to work with some of our CCOs a little bit more.
Great.
So I think that's less of a question and more of an offer. We're always happy to help make connections.
That's fantastic.
Let's see. Here's a question from Noel. So let's see. I'm a QMHP, Qualified Mental Health Provider, and work with mostly OHP clients. Our CCO Trillium has said one letter for MTF bottom surgery has to be from a psychologist. Also, that they must be qualified.
So the letters are not required by a psychiatrist or a psychologist. Letters are required by qualified mental health practitioners, and the policy with the Oregon Health Plan has outlined that qualified mental health practitioners are people who have master's degree. So they don't need to have a license necessarily. They don't need to be an LCSW or anything like that. They just need to be a master's level clinician. And they need 2 letters from master's level clinicians in order to access bottom surgery or lower surgeries.
Thank you. Do we have any other questions that folks would like to ask verbally? For Kevin,
I'd like to ask more about my question, if I might. This is Noelle.
Go right ahead.
Okay, so I went to a training back in January at Basic Rights Oregon in Portland, and I received the same message, which was you don't need a letter from a psychologist. However, I have it on good authority from more than one person that I've talked to, and from a client who has been denied and told that they need a psychologist letter. And they're also telling us that we need a psychologist letter from a qualified psychologist, meaning they have to be a specialist in transgender care. That is straight from the mouth of my CCO, and I have been round and round with them about this. So I'm wondering, does anybody have any information that will...
Yeah, what I can tell you, Noelle, is that Trillium is a CCO that we have had particular issue with, and by we I mean advocates here who are trying to push people for transgender care and coverage for transgender care. Don't know why Trillium is being specifically kind of more challenging than others, but if you give me your contact information, what I can do is I can put you in touch with someone at Basic Rights Oregon who is fielding these kind of rejections and these incongruencies in the policy, because it is a master's level clinician. That has been something that has been decided on, and
right. And
that's
according to WPATH,
yeah.
So I've been really frustrated with this for months and months and months. So that would be really, really helpful to me.
Yeah, absolutely. Yeah, because I want to make sure too that you have the correct information and that you're able to help your clients access letters, as quickly as possible.
Okay, great. Where would I send that information?
You can send that information to my email, which is on the last slide of the presentation.
Oh, I see it right here. Okay, that's really great. And I believe we're acquainted from the U of O a long time ago.
Probably, yes.
Yeah, we went to conference, I think, all together once.
I imagine
anyway, thank you. Anyway,
well, thank you, Jazz, for answering that. We've got one last question, I think, before we let folks go. This is from Trisha Bledsoe. And then she's asking, is there a list of providers currently providing surgery services and hormone replacement therapy services in the Willamette Valley?
Good question.
That is a great question. I believe that there is a list of providers who are offering hormone therapy, and if you go to OregonTransHealth.com, there's a PDF, and it kind of lays out providers by area, and so it starts with Portland and kind of the Tri-County area. There's a mental health practitioners list, and then as you continue scrolling down, it shows kind of providers in different areas. It is a working document, and so we're still working on finding providers. If you have anyone in mind or any thoughts, please email it to me or to the person who's organizing that list. In terms of surgeons, right now surgeons are very much limited to the Portland metro area. There has been talk about contracting with surgeons who have more specialty abilities in California or in other states, but that's something that's definitely still in process at this time. So right now the surgeons that we're looking at are in the Portland metro area.
And when we will send these slides out to everyone, and they're on there listed the resources that Jazz reviewed, so you can see what he said or where those lists are, because that should be in there. And maybe when we send the follow-up email, we'll try to call out a few of those as well, pull them out from the slides, so that you can all access the resources that were noted today. So a big thank you to Jazz and to Kevin for spending a little extra time to be available to answer questions. And thank you to all of you who got on this webinar today so that you can provide more welcoming care and help become more affirming and competent in the care that we provide. So thank you all very much, and enjoy the rest of your day.
Thank you.